Okay, so we'll talk about pulmonary embolism first. And as I said, we are not going to spend a lot of time looking at DVT. But if you remember, we said that pulmonary embolism is one of the complications of a deep venous thrombosis. The word embolism tells you that you have a thrombus that has found its way into circulation. If you have a thrombus is a combination of blood clots. So you have red blood cells being held together by platelets, and then red blood cell and platelets. So you form something like a clot. If this clot is actually stabilized at one place, then you say that the patient has thrombosis. But if this clot breaks away and then moves into circulation, then you say the patient has an embolism. Okay. And pulmonary embolism means that this blood clot that has broken away from circulation has basically migrated from the deep veins, and then it has ended up in the pulmonary vasculature. Okay, that is what it means. So if you remember the picture of the heart, you have blood moving, coming through your inferior vena cava, then it goes to the right side of the heart. Then from there, you have a right atrium, right ventricle, then it pushes through your pulmonary artery and then gets into your lungs. So if you have a clot that has formed in the deep veins, it's actually going to move through the same process. It's going to move through the deep veins and then eventually appear in the inferior vena cava or vena cava, and then move to the right atrium, right ventricles, and then from there, it would move through the pulmonary artery. And in very, very severe cases, because of how big the clot is, it would move through, but then it would just get stuck at that point of the pulmonary, where the pulmonary artery bifurcates. It just goes and then it gets stuck there. And once it gets stuck there, then it means you're in trouble. It means no blood will be able to move and then get into the lungs. And once you're not having blood getting into the lungs, you are basically in trouble. You are going to have issues. So that's one. Sometimes you can just move and then it just blocks just a small aspect of the pulmonary vasculature. In that case, you'll be breathless, but it wouldn't be so severe. So the severity of the condition is dependent on the area of blockage. So if sometimes you request for your CT pulmonary angiogram, which we'll be talking about, and we'll try and go to the net and find pictures. You talk about your CT pulmonary angiogram, and then it will give you a report and it will tell you that about 70% or about 80% of the pulmonary artery is blocked. Then it tells you that this is severe as compared to one that tells you that only 25 or 20% is blocked. So the severity of the condition is dependent on the blockage. Okay. So once you're using the word embolism, then it means that this clot is coming from somewhere. And that's why we always say DVT-PE. So DVT is you forming blood clots in the deep veins, okay, which we talked about. And then remember we said that basically there are three main things that will predispose you to forming a blood clot, and what we call the Verkhov's triad. And if you can see my screen now, and I projected the Verkhov's triad, so you can see that the first thing is stasis, the second thing is hypercoagulable state, and then the third thing here is endothelial dysfunction. In medicine, as I always say, you should never forget this Verkhov's triad, because wherever you find yourself, whatever department you find yourself in, you can have issues with thrombosis and embolism, whether you are doing pedics or you are doing adult medicine or you are doing surgery or you are doing ONG. All of these departments have risk factors that can lead to pulmonary embolism. So you always need to have like, your mind should be opened. And whenever you are seeing a patient, in assessing the patient, you should ask yourself various questions. Is this patient likely to develop a clot? What are this patient's risk factors for developing a clot? And there are numerous risk factors, but all these risk factors have been grouped under these three main categories, as you can see. So if you are going to admit a patient on the ward and this patient is going to stay for a very long time and the patient is going to be bedridden, then you're actually thinking about stasis. So then this patient is at risk of developing a DVT and later a PE. So what do? I need to prevent that. If you got a patient who has any of the clotting factor problems or coagulability issues and they tend to clot easily, either because they have excessive clotting factors or they have a diminished amount of the factors that are supposed to break down clotting factors, then you know that this patient is actually at an increased risk of forming a clot. So every single time you have to focus on this patient. And the thing about how hypercoagulable state is that amongst all these three, right, it is the only one that can stand on its own and cause you to have a clot. Having a patient in stasis alone is not enough to develop the clots. The stasis should have something else in addition. Stasis and maybe hypercoagulable state, stasis and maybe endothelial dysfunction. The same way, having endothelial dysfunction alone is not enough to form a clot. It should be with something else. But then with hypercoagulable states, just that can predispose you to forming a clot. So every now and then we need to review our patients, we need to know their risk factors, and we need to be prepared. It's quite criminal to have a patient on the ward for a very long time and later the patient develops a clot. We come and we go through your notes, you realize that you didn't take note of that and you didn't give any anticoagulation. The lawyer won't spare you. So you always need to be careful with such things. There are risk factors, and as I said, there are numerous risk factors, but they are grouped under the main three. So prolonged immobility, obesity, smoking, major orthopedic surgeries, abdominal surgeries, if you have a cancer, pregnancy, sometimes some drugs like estrogen, your oral contraceptive pills, all of these things will predispose you to forming a clot, okay? So if you go through their reasons for someone who has prolonged immobility, it tells you that the pathophysiology will be what? Stasis. For someone who is smoking, it tells you that the pathophysiology will be endothelial dysfunction. If you have a major surgery, then it means that you are going to be in bed for some time. That's one, and probably some blood vessels would have been damaged. So both stasis and endothelial dysfunction. Okay, if you have a malignancy and you are bedridden, stasis, endothelial dysfunction, and some of the cancers itself can cause your blood to clot faster than usual. If you are pregnant, you have some form of stasis if you are not moving around. And then pregnancy will also predispose you to form clots in terms of your clotting factors, okay? Estrogen has an ability of affecting your clotting factors. So this is more of hypercoagulable state. So it goes on and on and on. I don't really talk about the Walsh criteria. Just know that it's criteria that we use to assess the risk factors of someone developing a clot, okay? And it has a score. And usually if the score is 0, then it means that the patient is not likely. It doesn't mean the patient won't get a clot. It means the patient is not likely to get a clot. But if the score is above 3, then you know that the patient has a high probability of developing a clot, okay? So that's a Walsh score for you. Sometimes if you say, oh, someone has a positive Walsh score, then it means when you looked at all this, the patient got 2 or more. If you say someone has a negative Walsh score, it means when you looked at it, the patient had less than 2. Okay. So we are looking at P, so we won't really go into DVT. But then you remember we talked about calf pain and all that. Then we've also talked about differentials of DVT. And then we said that in managing DVT, the main aim is to prevent PE. Because DVT won't kill you, but the PE is what will kill you, and that's what we'll be talking about. So you are going to do everything in your power to sort of either melts this clot, prevents the clot from getting to the lungs. So whatever you can do to stop this clot from moving in circulation, you are going to do it. So in your management of DVT, your main aim is to prevent PE, meaning that you have to anticoagulate your patient. You have to extend the anticoagulation for quite some time, 3 to 6 months, okay? And sometimes patients can even be on lifelong anticoagulation if the condition that is predisposing them to having the PE is one that is never going to go away. If they have a coagulation problem and their blood keeps clotting every now and then, once you pick that up, they are going to be on anticoagulation for life, okay? And just a revision, we talked about some of the medications that we can give. We said we have unfractionated heparin and low molecular weight heparin. So I'll come back to this slide during our management. Okay. All right. Okay. So I think that's enough recap. We can go on with our pulmonary embolism slides. So we say that it's actually the main complication of DVT. Okay. And with PE, most patients would initially not show any symptoms at all. Nothing. Okay. But then once they start showing symptoms, they have something more of a classic, and people can show something more of a classic form of presentation. So they can't breathe, they have chest pain, and this chest pain is like someone is stabbing them in the chest, what we call pleuritic chest pain, okay? And then they also can develop some sudden lightheadedness. They can also develop some form of fever. Sometimes they cough, and this cough can be stained with blood. So you might say, oh, okay, with this difficulty in breathing, and then with this blood-stained cough, I'm probably dealing with some form of pneumonia or a TB. Okay, I mean, that's a differential you can entertain. But then you realize that with a TB, it tends to be chronic. The patient will tend to be coughing for some time. But with a PE, it's quite abrupt, okay? And then the patient would have these things that we've talked about. In addition to the patient's symptoms, there are also clinical features that this patient might present with, and that will give you an indication. Most of the time, that gives you an indication of a PE. It tells you that this is a PE. You need to intervene. But you can have a patient on the ward who maybe you've had a surgery for. Patient is just lying in bed, and then all of a sudden, patient goes like, I can't breathe. Sometimes they might not even show signs of breathlessness, but the nurse goes to check the vitals, and nurse comes back to tell you, look, the SpO2 is around 88. Then it should ring a bell. So you go and decide that, okay, let me check the SpO2 again and see what I'm dealing with. Maybe the machine is faulty. You check, it's still low. All right, let's use a new pulse oximeter. You check and it's still low. It tells you something that, all right, this patient just had surgery. That's one. All of a sudden, SpO2 is dropping. But you ask her, Madam, are you okay? It goes like, oh, I'm fine. But then clearly SpO2 is dropping. The next thing is quickly check your other vitals. Because usually with a PE, once you check, SpO2 is low, respiratory rate will be fast, even though patient tells you, I'm okay, respiratory rate will be fast. The pulse rate will be fast, okay? Your blood pressure would be low. So I'll take it again. In PE, SpO2 would be low, respiratory rate will be fast, what we call tachypnea. Your pulse rate will be fast, that's what we call tachycardia, and your blood pressure will be low. The reason why your pulse rate is going up is in response to the low blood pressure. And you remember what we said, that cardiac output is equal to stroke volume times heart rate. So whenever your cardiac output is going down, meaning that the blood pressure you're recording would also be low, your body would have to compensate. And in compensation, your pulse rate will tend to go up, right? So pulse rate goes up, BP low, or BP goes down, pulse rate goes up, respiratory rate goes up, and then SpO2 also goes down. And that should ring a bell that, oh, wow, I have a pee on my hands. You go ahead and you listen to the patient's chest and you realize that the chest doesn't sound normal. It doesn't sound vesicular. Okay, you can sometimes have some funny sounds there, what we call wheels. You can sometimes have that there. You can sometimes have a bronchial breath sound, like the way a pneumonia would sound, depending on how severe the infection is. Mind you, the reason why you are getting these problems is because the clots is stuck in circulation. Blood is not flowing to the periphery. And because blood is not flowing to the periphery, you are going to have what we call an infarction of the lung. So a pulmonary embolism will lead to a pulmonary infarction. And once you have a lung infected, meaning that area is dead, meaning the lung has lost that spongy feeling. And so you can't have a lot of oxygen concentrated in that place. That place is gone. So it becomes a little bit solid, like you are dealing with your pneumonia and whatnot. Okay, so you can actually feel the breath sounds tend to be a bit bronchial. Okay, and then also in your examination, you can see what we call cyanosis. So when you check the lip and the person is fair, you realize that the lips look a little bit purple. If the person is dark, you realize that the lips will look darker than expected, and they also tend to sweat a lot. So I'll give you one classic case. So recently, one of the facilities I work with, we had a patient coming to us, and this patient had, patient is pregnant, and during the pregnancy, we realized that the abdomen was getting bigger than expected. And usually your SFH or your symphysofungal height should correspond with your gestational age. So if we measure your abdomen and the abdomen is 20 centimeters, it should sort of correspond closely with your gestational age, maybe 20 weeks plus or minus 3, sort of. But this patient was just about 20, 22 weeks, but the abdomen was huge, like 30 or something. Like the abdomen was that big. Like she was almost getting to, gone past the third trimester and all that. So we did a scan and then we realized that her ovaries, both ovaries were huge, enlarged. So now we're worried. What can we be dealing with? Because they were that enlarged, like you have what you get in ovarian cancers. So we're like, okay, this is something else. Okay. So we had to operate or do a surgical intervention because the abdomen had become so enlarged. It was filled with fluid, because once you have the ovaries becoming big, it would irritate the peritoneum. And the secondary effect of that is that you are going to have fluid developing in the abdomen, what we call ascites. So apart from the fact that the ovaries were big and there's pregnancy, there was also ascites. So you can imagine how this patient was suffering. So we had to intervene, and the intervention we had to do at that point was a surgical one. So we took theater.
This is if you happen to meet him,
we took to theater.
So you would take that, and
so we took to theater.
You have to look in. Okay, let's listen.
All right, so we took to theater and we operated, and as part of the procedure, because we knew it was going to be a very, very painful one, we gave the patient what we call epidural analgesia. Epidural means that they are going to pass a very long catheter into the epidural space, and we do a combination of painkillers, bupivacaine, fentanyl. It goes in so that the patient won't have so much pain. So we did that. So we are done with our surgery. We bring patient to the ward. We've monitored patient and recovery. Patient is okay. We bring patient to the ward. But because we had put an epidural catheter inside, ideally after every surgery, you are supposed to give your patient some form of anticoagulation. But when you put an epidural catheter inside, you can't give anticoagulation. Anticoagulation means that you are preventing a blood clot. So it means the blood becomes thin. Whenever you have a cut or a puncture in your anticoagulation, you will bleed more than you're supposed to bleed. So if you have an epidural catheter inside at the back of the patient and you give anticoagulation, the patient is going to bleed into the epidural space, and that will also come with its own complication because the epidural space is very, very small. Once you bleed into that space, you are going to press on your nerves coming from that side of the spinal cord and all that. You can, basically you can't even walk. So we didn't give any anticoagulation. So I was on duty, and the nurse pumped me that the patient's, respiratory rate is not so good, and the patient's SpO2 is dropping. So I review, and then I realized, yeah, indeed it's dropping. And then quickly we checked the vitals. BP was going down, pulse was going up. But the patient actually said, "Oh, I'm fine, doc. Don't worry, I'm fine. I'm fine." But then in the end, it actually turned out to be a PE. The patient had developed a PE, and this patient was actually saying, "I'm fine." Okay, I'm telling you this story because most of the PEs are asymptomatic. And if you don't keep a close look, you don't look at the vitals well, you would miss it. Okay, so always look at risk factors. One of the reasons why I quickly talked about a PE was that, one, I knew the patient's risk factors, and risk factors here is that the patient is pregnant, the patient has just had a surgery, a pelvic surgery, so most likely a clot could have been formed. So that's it. The patient is lying in bed, so stasis. So with these risk factors in mind, I quickly went ahead to do examinations, and from the examinations, I said, "Oh, this patient has a PE." Now, the catch here is that usually when you diagnose PEs, which we are going to go to next, you need to do investigations. And as part of the investigation, it's good to do what we call a CT pulmonary angiogram, right? And CT pulmonary angiogram means that you are going to put the patient in a CT scan. And then, in addition, what you are going to do is you are going to pass a dye into this patient's vessels, okay, the veins, and then you expect that the dye is going to move all the way from the peripheral vessel and get to the pulmonary artery, and it would go and delineate or draw out the clots. Okay, so then once you take it, you can see that, oh, that's the clot there. And once we're done with the lecture, I'll try and project a picture of the CTP. So it tells you, oh, that's the clot there. But in this case, this patient is pregnant. So we are wondering, should we still go ahead and give a dye? And it comes with complications. You are trying to intervene, you go and give the dye, and then later baby comes out with one hand missing or one eye missing. They can sue you. So then we couldn't do a CTP. So we had to do other investigations, and then we still went ahead to manage as a PE, and our patients got better. Within 48 to 72 hours, patient was breathing fine. Okay, so always be on the lookout. Look out for risk factors. Make sure that once your patient starts saying, "I can't breathe," and you know you have risk factors, you are thinking about a PE. Okay, don't let anybody come to tell you, "Oh, this is a PE." It's always good to think sinister in medicine. As I always say, it's always good to think sinister, to think of the bad things and intervene before saying, "Oh, this one is some upper respiratory, it will go. She's just coughing. Let me give her amoxicillin, it will go." No, you always have to consider the serious things that can kill your patient before thinking about the less severe things, because in the end, that is what will make you a good clinician. All right, so to investigations, we can do a D-dimer. Usually, we take a blood sample for full blood count. When we take for full blood count in P, we've realized that usually WBCs tend to go up. So we call it leukocytosis in P. You can take a sample for your D-dimer. D-dimers also tend to go up. Usually, we don't want it to go above 0.5, but in P, you realize that whenever a clot forms, your D-dimer goes so high. We can do arterial blood gases to check the partial pressures of oxygen in there. Just like myocardial infarction, troponin has a very, very strange relationship with PE. So sometimes your patient, "I can't breathe," and you are thinking this can be a PE. You go ahead and do troponin, you realize that your troponin might be elevated. Okay. When you do a chest x-ray, you find, depending on the severity, you can find a triangular area that has been infected. We call that a Hampton's hump. Okay. So you find it on the chest x-ray. You can do an ECG, and the ECG would also show the tachycardia we talked about in the presentation, and something called Magen-White syndrome, okay, where you are going to see some changes on your ECG. Then you can do a pulmonary angiogram, CT scan. We usually combine the two and call it CTP, CT pulmonary angiogram. So that's how the Magen-White sign would look like, okay? So once, this is usually it's difficult to keep in your head, but just have this S1Q3T3, okay? S1Q3T3. And that means that when you take your ECG and you look at the leads that have been named lead 1, lead 2, lead 3 on your 12-lead ECG, you are going to find changes. Last time, remember I said when you take your 12-lead ECG, you find lead 1, lead 2, lead 3, you find AVR, AVL, AVF, and then you find V1, V2, V3, V4, V5, V6. It makes it a 12-lead. So with your Magen-White sign, it means that when you look at lead 1, you are going to see S wave. S means that, you remember we said QRS complex. Okay, so you can see a QRS. The S actually dips down. So clearly there's an S wave. So you see an S wave in lead 1. When you come to lead 2, you see a Q wave, meaning that the Q is classic. It goes down, Q in lead 3. Okay, and then also it gives you an inverted T wave in lead 3, which you can see. Remember your ECG, the normal, let's say we can actually use this. So this is like a P wave, this is a QRS complex, and then there's a T wave here sometimes. Okay, sometimes the T wave can either go up or it can come down. So
sorry, I missed that. Did you say?
So you can have an inverted T wave on lead 3, and that's what we call the Magen-White sign. So clear S wave in lead 1, clear Q wave in lead 3, and an inverted T wave in lead 3. Okay, once you see this, this usually points to a P because it indicates an acute strain on the right side of the heart. Remember, the pulmonary artery is on the right side. Once it becomes choked, then the right heart side will still keep pushing blood, so there's a strain. So when you do your ECG, you find it. So someone will say, oh, if we are talking about the lungs, why should it show on the ECG? Because the effect, whatever is happening in the lungs is going to have an effect on the heart as well. Okay. So complications, you can have sudden death. So someone will say, oh, it was just fine, and he just fell down and he didn't wake up again. That's P for you. It can lead to shock. Okay. It can lead to cardiac arrest, which we talked about. So pulseless electrical activity and all those things. It can lead to arrhythmias. You can have a lung infarction, means that part of the lung is basically gone. You could have a pleural effusion, and you could have a cor pulmonale. Cor pulmonale means that you have a right-sided heart failure, which is secondary to a problem coming from the lungs. Okay, that's a cor pulmonale. So it's a right-sided heart failure, secondary to a problem coming from the lungs. So how do we manage this? So remember with DVT, we said that make sure you prevent a PE. So you give medications to prevent it. But if you are not able to prevent it and it gets to the lungs, then now you have to manage it anyways. So how do you manage it? In preventing your PE from happening, what we do, please hold on for me a bit. Okay, welcome back. So your management, you can see that now the clot has already formed. The thing has gone all the way up and gotten into the lungs. We want to break down the clot that has been formed. That's one. And then two, we want to prevent other clots from forming. So it means we are going to break down the clot, and that's what we call thrombolysis. And we are going to prevent other clots from forming. That's what we call anticoagulation. So these two things, okay? There are also other things where surgically we can remove the clots that has been formed, what we call embolectomy, or we can go ahead and then we put filters. Okay, we put filters in the inferior vena cava to prevent the clots from moving all the way up to the lungs. So basically, this is more prevention. And also we can use a TED stockings, which TED means thromboembolic deterrent stockings. It's not a name of a person. Thromboembolic deterrent stockings. We can give that, which I told you about in the past. So this is also more prevention from further clots from forming. But back to the management, what we are going to do is ideally within 24 to 48 hours, you should be able to institute thrombolysis, okay? And you can give your recombinant tissue plasminogen activator, which is verticase or alteplase. Usually you can give about 100 milligrams of that to run, like it's more of an IV perfusion sort of to run within 2 hours, okay? Once you do that, then we say that, okay, there's complete, you've put up a mechanism for complete thrombolysis. Okay, so you can always refer to the dose from Medscape and your standard treatment guidelines. So that's it. The next thing is anticoagulation. And with anticoagulation, I told you that we have, we go through different processes during anticoagulation. So one, there's the initial anticoagulation we are going to do, and then now we leave the patient on a certain medication. Okay, so what do? The thing is that we know that medications like warfarin and all those ones are excellent medications for anticoagulation, but the problem here is that you usually can't give them in the early stages. Reason being that if you're giving only warfarin in an early stage of a PE, by the time you realize your patient will be gone, because it takes time. It takes time to reach its maximum efficacy to be able to work, sometimes within 48 to 72 hours. So if you are just giving warfarin, first day, second day, nothing will happen. Nothing happens. So you need to give something first. Then you are giving warfarin in the background. By the time you move from what you've given in the initial phases, warfarin would have hit its higher level and it will start working. Okay, so that is the mentality behind it, and that's why we usually see us giving heparin and then warfarin, and then we'll taper off, we'll stop the heparin, and then the patient takes the warfarin. Okay, so usually we have unfractionated heparin and we have low molecular weight heparin. Unfractionated heparin comes with a lot of side effects, as the name suggests, unfractionated. Okay, so it contains a lot of impurities. And then you have your low molecular weight heparin, and the two classic types that we have here in our environment is enoxaparin, which is also called Clexane, and dalteparin, which is called Fragment. Okay. Know that with these medications, there are two different dosing forms. We have what we call the prophylactic dose, and then we have what we call the therapeutic dose. Usually, if we see that our patients have risk factors, what we give them is a prophylactic dose. But if the patient goes beyond a risk factor and has the condition, then you have to go ahead and then you do a therapeutic dose for your patient. Okay, so sometimes if you take Lexine, for instance, you can see that, you're giving patient 40 milligrams daily. That's a prophylactic dose. But once a clot forms, we will calculate the dose per the patient's weight. As you can see there, we are going to give about 1.5 milligrams per kg to this patient. So sometimes we give between 1 to 1.5. So if your patient is 80 kg, then it means that a prophylactic dose will give half of that. So we'll give the patient 40 mg. But in a therapeutic dose, we are going to give this patient between 80 to 120 mg. Okay, so you understand how we calculate it. So therapeutic doses, we go higher than prophylactic dose. And then your dalteparin, you can see that your therapeutic dose here is 200 units per kg, but you don't have to exceed 18,000 units. Okay, the dalteparin is also known as fragment. All right. So once you initiate your heparin therapy, you're also giving your warfarin, which is inhibits vitamin K. Remember back in the day, primary GHS, we say vitamin K is good and it helps your blood clot. If you don't have vitamin K, then it means you're going to bleed. But this time around, the blood has already clotted, so we don't need vitamin K. So we need to give you something that will inhibit vitamin K, and that's where warfarin comes in. Okay, so we'll usually continue both the heparin and then the oral warfarin for about 3 to 5 days until warfarin would reach its efficacy. And once it reaches the efficacy, we drop the heparin and then we play around with the dose of the warfarin. Okay, it is essential you play around with the dose of the warfarin because if you keep a patient on one dose, a higher dose for a very long time, your patients will go beyond the stage of clotting to bleeding. We've had cases where we give patients warfarin, we leave them on warfarin like 15, 20 mg, they are on it, and then they come back to you with a hemorrhagic CVA because they end up bleeding. Okay, so you need to be careful. Once you're starting your dose of warfarin, you start at a lower dose and you titrate, and the titration is done based on your INR. So what is INR? Remember I told you INR, you're just looking at a ratio of the patient's prothrombin time to a standard prothrombin time. Okay, and usually INR, normal INR in a healthy person should be between 0.9 to like 1.1 sort of, or it should be below 1.1. That's a normal INR of a normal person. But if a patient, you're managing a patient with a clotting problem, you focus on an INR between 2 to 3. That is what we call the therapeutic INR. Okay, so you let your patient do the INR whilst on the warfarin. If your patient's INR is above 3, then it means that no, this patient is bleeding. So let me drop the dose of the warfarin. If the patient's INR is below 2, then it means no, I haven't hit the effect here. The patient is still clotting. So let me increase the dose of the warfarin. I'll take that again. So you look at your INR. If the patient's INR is above 3, then if you remember ratios, okay, so try and picture this. We say INR is PT of the patient over the PT of the standard. Okay, patient's prothrombin time over the standard prothrombin time. Okay, prothrombin time is the time needed. It tells you that, oh, okay, the patient's clotted faster or the patient bled faster, right? So if the patient's prothrombin time is higher, then it means that it takes a very long time for the patient's blood to clot. Are we okay? If the patient's prothrombin time is shorter or is quicker, then it means that the patient's blood clots faster. So if you look at a ratio and you are having a patient prothrombin time which is higher than the standard prothrombin time, very high, then it means that definitely your INR is going to be more than 3. And that tells you that your patient is likely to bleed. But if the prothrombin time too is smaller, or the patient is smaller than the standard prothrombin time, then it means you are going to have a value that is small. So it means the INR is going to be what? Less than 2. And that tells you that no, your patient is clotting faster. So definitely you need to increase the dose of your warfarin. So that's how we increase and we play around with our warfarin. It's very, very key that you do this every now and then during management of your patients on warfarin to prevent them from bleeding, okay, until you get a standard dose, maybe 5 milligrams or 10 milligrams a day, which keeps them there. Also, if you don't want to give warfarin because monitoring warfarin is so difficult, now we find it so challenging because you have to be doing repeated INRs and whatnot, and then the risk that warfarin comes with in terms of bleeding. There are new medications that you can give. We have something called rivaroxaban or Xarelto, okay? And Xarelto affects factor 10. Whereas you see warfarin affects vitamin K, Xarelto affects, it's a factor 10 inhibitor, okay? And with Xarelto, you don't need your INR for management and in fact, for, observing and checking to see that if things are going on well. You don't need your INR for monitoring, okay? However, if you're given very, very high doses of rivaroxaban or Xarelto, it's good to do a prothrombin time. Usually that is what we tend to monitor with. But even that, your usual standard dose of rivaroxaban or Xarelto, so you don't need monitoring. But if you think you need monitoring, then you are going to look at your prothrombin time. Okay, if your prothrombin time you are getting is so high, then it means that your Xarelto is causing your patient to bleed. That's why the prothrombin time has gone up. Okay, so we already talked about prophylaxis here. So we are bringing the lecture on pulmonary embolism to a close. I didn't expect it to go too long, but I think we had some details we needed to touch on. So before I pause the recording and start the next lecture, I'll take your questions and then we can go on. Yes, please.
With the rivaroxaban, I was a little bit confused because if I should give that, I don't know whether after monitoring or after giving the initial heparin or something before starting the rivaroxaban. Now, if I start that, or maybe after the heparin injection, and then I realize that maybe INR is now normal or is now getting to normalcy, and I decide to maybe put the person on rivaroxaban and now hold the heparin, is that allowed, or will I still have to monitor INR whilst on that? And how do I know that with the rivaroxaban the person is now okay in terms of normal INR if I'm keeping the patient on only that one?
All right. Okay. Yeah. So that's a good question. So for the reason why we even do the INRs in the first place, if you're giving your warfarin, is to ensure that you are within your therapeutic range, to ensure that your patient is either not bleeding too much or clotting. Okay. But for rivaroxaban, you are giving that and you actually don't need your INR. Once you are giving, remember, we always say that you are not managing labs alone. You are actually managing the patient sitting in front of you. So you are actually looking at your clinical presentation of the patient. Okay. And I like the way you said it. So you give your heparin and all that, and then you realize, okay, patient is okay. So now you want to stop your heparin and then give your rivaroxaban. Yeah, fantastic. But once you're giving your rivaroxaban, we usually have like standard doses. So if you look at your Medscape, it will tell you that, okay, if you have a P, maybe give maybe 15 to 20 milligrams daily, or give this. It will give you a standard dose that you should go for. The reason why you'll be prompted to monitor is, all right, okay, maybe for curiosity's sake, you want to see if this rivaroxaban you are giving is increasing your prothrombin time more than normal. If it is, then it means that your patient is bleeding, but usually you don't even need it. Okay, so that's the advantage it comes with. So if you read more about rivaroxaban, it will tell you you don't need constant monitoring. All you need is to make sure to tell you that, oh, my patient is doing well. How do we know that the clot is gone? We can analyze that, because that one we need a more visual thing to tell us than just a PT time or something. Because sometimes your PT might also be just a little below, and that tells you that, all right, okay, patient is still at a risk, so maybe let me increase my rivaroxaban. But the thing is, once you start with your standard doses of your rivaroxaban, it works, and you only come back to monitor just to be sure that your patient is not likely to overbleed, because most of the time that's the side effects that we have. If you give too much rivaroxaban, then it means prothrombin time will go up and your patient will bleed. So that's why we come to check. But to see if the clot in the lung is gone, the best way is to do a repeat CTPA after your treatment. You understand? Are you okay with that, Daniel?
Yes, sir.
Great. So
Yes, sir.
the best way is to see for yourself, to see a picture for yourself. So one picture you can see is the patient sitting in front of you. Is the clinical state improved? Has the pulse dropped to the normal state? Is the BP going back to normal state? Is the SpO2 good? That is your first picture. And your next picture, what is the repeat CTPA saying? You understand? So that helps you monitor your management better than just going to do a PT to see if you are giving enough dose of rivaroxaban or not. Okay?
Yes, sir.
Great.
So, sir, in a situation where maybe you don't have the facilities or the equipment to do the INR immediately, can you focus on the proton beat time to start your treatment?
Oh, yes, but you see, once you can do a proton beam time, you can calculate the INR
Okay.
because you just need the patient's proton beam time. And whatever you are using to do, it has a standard proton beam time, so you can calculate it yourself.
Okay.
Uh-huh.
Okay. Thank you, sir.
You're welcome. So basically, yeah, so this is it for P. Any other questions before we quickly switch to our next one? So if I give you a question on P, or you go out there and you have a patient with P, you should be able to manage the patient, right? You should be able to manage the patient. Always think, one, what are the risk factors here? Can I prevent them? Let me go ahead and prevent them. Okay. Two, I can't really prevent them that much. So like in our case, the case I gave you, epidural catheter in there, you can't give prophylactic anticoagulation. Even when you remove your epidural catheter, you have to wait for about 6 hours before you can start prophylactic anticoagulation. That's how serious it is. So what else can I do? Okay, let me give my patient TET stockings and just pray that my patient will form a clot and throw an embolus. And once I know that I've given TET stockings, there's epidural catheter in there, I'm not giving prophylactic anticoagulation, then my patient is at risk of developing a clot. So let me monitor my patients more often than the way I monitor my usual patients. Okay, so that's how you handle such a case. Okay, so I think I'll stop the recording here so that it can save, and then I would pick up the next topic. Thank you. Before I go, let me try and see if I can show a picture of a CTPA before we move to the next topic. Thank you. All right. Can you see my screen, please?
Yes.
Great, great. So, you can see, I mean, we'll be talking about, if there's time, we'll be talking about COVID too. Remember we said one complication of COVID is basically pulmonary embolism, right? So, really when you do your CTPA, so there's like a CT scan, and then there's a pulmonary angiogram. So the angiogram here means that you've introduced some dye to go through, and it's eventually got into the pulmonary artery. So you can see how it will look. It would actually delineate the parts where you have the thing stuck, and beyond that where you have your infarction. It will just show it for you. See, so you can see that when you look at this, yeah, I can't really see any clot here. So this looks like a normal one. So you see, when you introduce the dye, it goes through the whole thing, as you can see over here, and then it draws out the lungs for you. You can see it. So it draws out all the various vessels for you. So if there's a blockage, then clearly you can see that distal to that part, you are not going to see anything of that sort. Okay. So CT scans, you can either have like a coronal section like this, meaning that they cut it from the front, or you could have like a transverse section like this, meaning that they cut it sort of, how should I put it? Through the middle, sort of, from side to side rather than from up to down. So that's how it would usually look like. Okay. So there's also an example, as you can see over here. So I'm showing you this because in the ER, you request for it, and when it comes, it will come with a report. But sometimes it's good to be able to look at the picture that you have, and then it's good to be able to point out that, oh, okay, this is actually what we are thinking about. Okay. Let me see if this is a good picture. So, doesn't show it clearly here. Okay, this is perfect. So you can see that the dye has been introduced, okay? It has been introduced nicely inside here, and it's outlining it. But then there's some parts, so that's the white part here that the dye has been introduced. So that's the white part. But you see, beyond it, you can see some dark aspects where it's like the dye doesn't get there. Do you get it? So it doesn't really get there. So that tells you that, okay, there's something blocking, and this is preventing the dye from actually getting to this side. Okay. And so it points out to you that indeed there's a clot, or there's something staying there which is preventing the dye from getting to the whole part. Okay. All right, great. So let me put up the next lecture, and then we can move on. Okay. All right, Dorothy, let me take your question before I put up the next one. I can see your hand.
Dr. Mita, please. My question is with the contrast CT.
Yeah.
I only know of making sure the kidney functioning, the kidney is functioning well before we use it. So apart from the kidney, is there any concern, any organ concern that we need to actually?
No, to worry about. Okay, so mainly it's the kidneys we tend to worry about, because the kidney is what excretes the contrast, you see. So if your kidneys have a problem, then it means you'll be unable to excrete the contrast. The other thing that ideally we should also be worried about is maybe the liver, because the kidney and the liver is what gets rid of waste substances. But the thing is, we still use this contrast to delineate hepatomas and hepatocellular carcinomas and whatnot. So it tells you clearly that the substance being used, which is the gadolinium that is being used, is excreted by the kidneys. So we don't really worry about the other organs so much, except in the case that I gave you, that in pregnancy, we are not so sure. If you read some books, it will tell you that, oh, you can do a CTPA, but then you go ahead and you go and do it, and you have issues if baby comes out with some form of abnormality. Meanwhile, maybe baby is coming with their own abnormality. Then you go ahead and you use a contrast, and they'll tell you that, well, some studies say 0.001% of babies can develop this from this. Then you are in trouble, because maybe that baby is at 0.0001. So ideally, in adult medicine, pediatric medicine, if you want to do it, you need to check your renal function test really before you can go ahead and do it. The other thing I would also say you should worry about is, okay, you are going to set a line for a patient to do a CTPA. You need to be careful about certain things. Let's say if your patient has a clotting factor disease and the patient tends to bleed a lot. Okay, maybe a patient who has prolonged bleeding time and whatnot, then it means maybe that might also restrict you a little bit, because once you pierce, patients enter bleeding, and then you have a problem. But apart from that, you should be able to do it once your kidneys are fine. Okay.
Okay, Dr. Minta, please, is it contraindication in breastfeeding mothers?
No, it's not.
Okay.
If the need arises, a breastfeeding mother gets a PE and we need to do a CTP, we have to do it. Okay.
Okay.
After that, we are not so sure. We are not so sure if the mother can breastfeed or not. You know that the substance has a half-life. You can always take a look at it. And you expect that 24, 48 hours, you should be able to excrete it. You can always hold on with breastfeeding and come back later. So no, it's not contraindicated.
Okay, thank you.
All right, okay. So, yes, so this brings us to an end of our PE lecture. Let's try and then we move on to the next.